welcome you to the concept of perspectives and activities in health equity that kind of got me to this point. And I hope this kind of a launch is putting a bug in your ear about what you may be able to contribute to our seminar series, because it's work that we want to hear that you have done as part of our group of practitioners, of equity practitioners. So I'm just going to indulge a little bit. My journey started as a trauma surgeon 20 years ago now, meeting people like Michael. And this is a painting that Michael painted a few years ago. He was a patient of mine who suffered a gunshot wound to the brachial plexus, which for those of you who don't know, the brachial plexus controls movement and sensation of our arm. And Michael was right-handed, and he was shot in that region that he's holding there, and learned how to paint as a result of someone in our violence prevention program who was giving his time, who had lost his son, but wanted to give back. And so Marco Razzo was the artist that taught Michael how to paint something like this with his left hand. And this is why we need health equity. It is a socially driven necessity in our medical system for people to truly heal. So that's the surgical perspective that I'm going to try to drive home to you today. So most of you on this call know that structural racism is indeed the normalization and legitimization array of dynamics. Oh, I think I've been muted. There we go. Array of dynamics, historical, cultural, institutional, interpersonal, that routinely advantages whites while producing cumulative and chronic adverse outcomes for people of color. And the best known of this, of course, is redlining. And here you see our city of Los Angeles and how permeating this redlining has been and has led to a huge impact on the social determinants of health. And those are, of course, conditions in environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. And in fact, it is all about health outcomes that social determinants impact in such a big way. And I'll show you a view of that from a surgical perspective. The impact of social determinants is tremendous, and traditional medical teaching does not focus on this, although socioeconomic factors contribute 40% of our overall well-being. And sadly, physicians know this, but only 20% of physicians are confident in their ability to address the unmet social needs. And in order to really understand this, we need to build a team of researchers around this notion so that we can come up with and implement solutions to this issue. So what does it look like outside of the world of surgery? Well, it starts way back with slavery and then these structural components of racism. And now people sometimes say, well, there isn't anything legal about structural racism anymore. But in fact, the downstream impact is tremendous and continues to be, from poorly funded schools, poor access to capital. All these things are still happening to cause toxic stress. And in this example, poor cardiovascular health and stroke outcomes as a result. And now to bring it into the realm of surgery and trauma, which is my clinical specialty, the severity and disparity of homicide in youth and young adults is very clear. It's the #1 cause of death in young African-American men, and it's #2 in Latinx or Latino men. But violence and chronic disease overlap in a big way. They are just the structural downstream impacts, and there's so much that they have in common, even though we don't think of surgical disease a lot of times in the same way we think of chronic medical conditions. But indeed, the reasons for all of these are way upstream. If you look at power plants in Los Angeles County and homicides, it overlaps almost perfectly. And this impacts not only the elderly population, but it impacts the 5-year-old who has a much more likely chance of having asthma. If you go to unemployment rates and homicide, a complete overlap again in our county. You look at diabetic amputations, which is a sign of poorly controlled diabetes or lack of access to quality care, and homicides, and there's an overlap. Poverty, of course, and homicides, huge overlap. These are areas of high social vulnerability. And then you look at food deserts. So just mapping out, and I'm picking on Trader Joe's here, but you see this donut of Trader Joe's, a rim around areas of homicide. So the overlaps are very clear with food deserts as well. And most recently, the inequities of COVID-19 have really highlighted this complete inequity in wellness. So when you're a trauma surgeon, you sometimes feel like you're standing at the bottom of a waterfall. And it didn't seem right to just be operating on somebody and sending them back out, sending our people back out to the same environment. So climbing upstream is really critical. And the rest of my short period of time here is going to be about how we're climbing upstream in the surgical field. So poverty and racism, these are the things that we need to focus on in order to truly impact the overall wellness of our populations. The American College of Surgeons has gotten involved in this. That's our umbrella organization as surgeons. And we had a summit on firearm injury prevention a couple of years ago and had 41 organizations from around the medical fields talk about firearm injury in the United States. And one of the focal points, as you see from public health intervention side of this visual abstract, is in fact the social determinants of health. And so we started an organization called ISAVE, or the Improvement of Social Determinants to Attenuate Violence. And yeah, you can kind of get ISAVE out of that. And we developed 4 themes: the development of a nimble curriculum for trauma-informed care. And I'll touch on that in a moment because it's coming to UCLA very quickly and we really need social scientists to help us evaluate it. Creating a roadmap for investment in at-risk communities, integrating social care into medical care, and then really what is our role as advocates? I'll touch on those briefly. And trauma-informed care is appreciating that there is an event, there is an experience, and there is an effect as a result of all of these aspects. And becoming trauma-informed in a trauma center, or I would argue not just in trauma, but all of our patients, is being proactive in developing a framework that is grounded in an understanding and a responsiveness to the impact of trauma, not as an event, but as a way of life, unfortunately, for many people. And so there are 6 principles. One is safety. The second one is trustworthiness and transparency. There needs to be peer support, and that gets into the social care aspects. Collaboration and mutuality, empowerment and choices. Cultural, historical, and gender issues we respond to them. And a systematic type of trauma-informed care is where a hospital, where the personnel practice trauma-informed care and exemplify Martin Luther King's beloved community. It is stopping our poor coping skills by normalizing violence and by normalizing injury in our populations. And what do I mean by that? Sometimes you'll hear in an emergency department things like, oh, I bet he was just on his way to church. These are things that are poor and not trauma-informed, and we can build ourselves around stopping it. Trauma-informed care is woven into the practice of all providers, and that's what we're developing right now at the American College of Surgeons level. We're piloting it, as I mentioned, at UCLA and at Harbor, and several trauma centers across the country. And the second aspect that we're working on is the knowledge that health and wealth are completely interrelated. And here's a persistent wealth gap that exists in Black and white Americans, as you can see here. And if you focus on this bottom part of this slide, you'll see Black Americans are overrepresented in 9 out of 10 of the lowest wage jobs considered high contact essential services during our COVID pandemic. And look across those and see how many are our people. They're side by side with us in our clinics and in our hospitals. This is us. So building a roadmap to investment of at-risk communities, again, takes people like Helena Hansen to help us to study how to do this, how to implement it, how to measure our strategies. So building external partnerships, providing opportunity for community to have a voice, leveraging our Affordable Care Act, community health needs assessment, and the community benefits program through the Affordable Care Act. These are really important aspects that we really want to focus on in order to build investment in at-risk communities. And the Healthcare Anchor Network is something that UCLA is looking into now, is a group of institutions that are very focused and primed to invest in community. And then there's the social care mission, and this is so critical in order to address these social determinants of health. So designing healthcare delivery to integrate social care into healthcare, and I'll give you a quick example in a moment. Building a workforce to integrate social care into healthcare delivery. Community health agents are so critical in this, and funding and conducting translating research and evaluation of social care integration models is an absolute need. And so just a quick example, a 22-year-old patient suffers a gunshot wound. And say you just, as a resident or an intern, you write an order that says discharge. But what does that truly mean when you write a discharge order? What if your patient lives on the 3rd floor with no elevator? The patient provides for his or her entire family, relying on a rehab center to arrange an appointment. The girlfriend has to take off work to care for both him and transport him, all these aspects. And then when someone doesn't show up for their follow-up appointment, what do we say? They're non-compliant. So this is a broken system that we can fix through efforts in health equity and social care. Hospital-based violence intervention is one model. It is a public health model in injury prevention. It seizes the teachable moment when somebody is in the hospital after a violent injury. It provides long-term case management and links to risk reduction resources. So it climbs up the waterfall to begin to really mitigate the social determinants of health. And it works like this. An intervention program is developed in hospitals, and now there are over 50 in the country. And a community health worker, someone with a lived experience, a credible messenger, goes to the bedside just like I would as a trauma surgeon to address a violently injured victim and develop a relationship that lasts several months, if not longer. And the client and the intervention specialist, we did a qualitative analysis on this, and you can see some of the themes that I don't have time to go into here, but you can see how some of the themes developed and how important this credible messenger, this person with lived experience, is to our patients, to the people who have experienced violence. And we did a decade of hospital-based violence intervention, benefits and shortcomings, and found really that employment and mental health services in the reverse order were number 1 and 2 most important things in order for somebody to not be re-injured within a 10-year period. And we have the Health Alliance for Violence Intervention, which is the umbrella organization for hospital-based groups around the country. So again, this is one example of weaving social care into medical care. And then the final theme of ISAVE is advocacy. And I just want to draw your attention to the infrastructure bill at the bottom of this, the $5.3 billion towards violence prevention that the Biden-Harris administration are now working to get through Congress. There's another $1 billion that our Attorney General just mentioned will go into the justice system to pay for models in hospital-based violence intervention and other community models that have shown promise. So we are getting there. And the executive director of the HAVI was at the White House when this was announced in the Rose Garden. We also at UCLA have the Program for Advancement of Surgical Equity, along with my co-director there, Katrine Juilliard. We work both locally and globally. And ultimately, we would love to work with our partners on both sides of the street to develop a model where we can focus on social determinants of health within our medical care system. And we're really excited about that, and have some wonderful, wonderful colleagues working in this capacity. And this is really the time. It's an inflection point. It's a time for transformation. So I am again blessed to have a colleague like Helena Hansen, who can really lift up these concepts by having the expertise in the social sciences to be able to study not only the implementation, but the outcomes of these efforts. Thank you. I'm going to stop sharing my screen.
Thank you so much, Rochelle, for that brilliant illustration of what you have called equity care and the absolutely urgent nature of our need to invest in it and to research it. So I'm going to, in my time, before we get into the weeds of what our new research theme is going to look like, both Rochelle and I thought we'd start with some self-introductions and a little bit of a flavor for what the work that we've done prior to this theme looks like. I'm going to try to highlight, let me put on screen. Let's see. Oh, actually, for some reason, here we are. Okay, for a moment I lost screen sharing. Okay, and hopefully you're seeing my screen now. Yes, okay. I'm going to try in my self-introduction to illustrate what I hope the social sciences can bring to the vision that Rochelle just laid out. And I'll start by saying that I am an addiction psychiatrist and a cultural anthropologist by training. And I come to UCLA just a few months ago after 15 years in the psychiatry and anthropology departments at NYU. So all along, I've been primarily a researcher, and I've done a range of studies from community-based alternative approaches to addictions and mental health. And I'll give a couple examples in a moment. All the way to the racialization of the science and technology of addiction treatment. But my research all along has been deeply informed by my clinical work as an addiction psychiatrist at Bellevue Hospital, New York City's largest public hospital. And I just want to take a moment to mention how profound it's been for me to work with art therapists and peer counselors there, where I co-led a video therapy group and a community performance group in which patients who were referred from homeless shelters and jail and prison systems around the city found a sense of connection, meaning, and common purpose by making films and putting on musical, spoken word, and theatrical performances. So that clinical experience greatly expanded my idea of what clinical treatment could be, and my idea of health equity through community engagement. And so again, on a biographical note, I want to explain that a little bit about what led me to combine social science and medicine in my career. I came of age during the height of AIDS activism. So this was in the late 80s, early 90s. My first job out of college was working as a program officer for the National AIDS Fund. So in that role, I was giving grants to grassroots community leaders and activists who were starting their own AIDS programs in the wake of widespread neglect by the healthcare system. So my early experiences with medical crises in underinvested communities marginalized by race, ethnicity, sexual orientation, and AIDS stigma itself were actually inspiring because I saw how alliances between activists who were HIV positive or caring for HIV positive loved ones, between them and proactive, concerned clinical practitioners led to major changes in the ways that healthcare and medical research were conducted, at least when it came to HIV. So these alliances led to the inclusion of people infected or affected by HIV in designing clinical trials, in allocating research funds through NIH Review Section membership, and in allocating Ryan White Care Act funds for medical services in local communities. These activists also developed systems of mutual aid and HIV education through, for example, house parties, and also through peer navigation. They really inspired me to apply to the MD PhD program at Yale as the first social scientist in that program. So as I told the admissions committee there, given the power of social determinants of health outcomes, which were beautifully explained by Rochelle just now, I felt that MD PhDs should bring not only insights from the laboratory bench to the patient bedside, which is what the joint training program had originally been designed to do, but I also felt that the MD PhD program should bring insights from community research to the bedside. And once I started work on an MD PhD in anthropology, I got interested in systems of care for addiction and mental health problems. I didn't know it at the time, but this was probably due to my early experiences with structural drivers of health inequalities. I grew up in Oakland and Berkeley, California, at a time of deinstitutionalization through the closure of state mental hospitals, followed by cuts to community mental health funding. And as a result, 3 out of 4 of my uncles who struggled with mental health and substance use problems went in and out of jail and short-term clinical treatment, only to end up on the streets. So I lived in fear of them showing up in a rage at my house, where my mother, a single parent, was often away at work. So I've seen up close the toll that the broken mental health system had on my mother, on my grandparents, who had nowhere to turn for help, who grieved the early deaths of my uncles. And it's given me a critical lens through which to study structural, and by that I mean institutional and policy level causes of health inequalities. My early work with grassroots AIDS activists also led me to look for alternative community-based responses to addiction and mental health problems wherever I was. I had seen how widespread evangelical addiction ministries founded and run by self-identified formerly addicted people were in inner city Black and Latinx neighborhoods across the US and in the Caribbean. And as a result, I spent 2 years doing fieldwork among these ministries in Puerto Rico, where addiction ministries outnumber biomedical clinics as state licensed treatment providers. And I ended up writing my analysis in my first book, Addicted to Christ. What I found was that the ministries provided a route to advancement and dignity among men who had few other options other than drug trade in the deindustrializing landscape of Puerto Rico, whose industries had relocated to cheaper labor markets in Asia. So men who were shunned by their families and neighbors as addicts could become spiritual authorities through conversion and their leadership of homegrown drug rehabilitation programs. These programs were surprisingly willing to collaborate with medical clinics. So for example, in Puerto Rico, many of them sponsored on-site HIV testing and provided transportation to HIV clinics for their residents, just as one example. So this made me think also about the potential for collaboration between these kinds of grassroots community organizations and practitioners. After my study of the cultural logic of addiction as a spiritual problem, which is the way it was framed in these clinics, I started a decade-long study of the cultural logic of addiction as a brain disease. So I was a psychiatry resident and then an addiction psychiatry fellow in the moment of the media coverage of the white opioid crisis, and also the moment that public hospitals in New York City were unveiling buprenorphine maintenance for opioid use disorder. So I was a participant observer of the emergence of the field of addiction medicine itself. That's a field that's grown immensely over the past 20 years since the quote unquote white opioid crisis was announced. And I analyzed the opioid crisis, how it was racialized as a white crisis through unspoken racial assumptions that were built into the neuroscience of addiction, pharmaceutical development and marketing, drug regulation, and media coverage of the quote unquote new face of opioid addiction. So all of these sectors have had a profound impact on drug policy and racial inequalities in addiction treatment, as documented in my forthcoming book, Whiteout: How Racial Capitalism Changed the Color of Heroin in America. But overall, the connecting thread of my research has been understanding how policies and institutions drive inequalities by race and class in health. with addiction and psychotropic drugs being a particularly useful lens for understanding this. And I now will spend a little bit of time on a project that I've also been working on for almost 10 years now, trying to bring insights about the structural drivers of health from social sciences of medicine into medical education and practice. So I've been building a national network of collaborators around the concept of structural competency. Structural competency is a term that I and colleague Jonathan Metzel, let me go back to this, introduced to systematize the ways that clinical practitioners can address social determinants in their practices. And I think Rochelle Dicker just gave some beautiful examples of that. So not to spend too much time, but we systematized ways that clinical practitioners can begin to engage with structural drivers of health. And this is a summary really of the steps, which I think also are applicable not only to clinical practice, but clinical research. So that's something maybe we can talk about in our discussion. But just to give you a flavor of structural levels at which clinical practitioners in our network have addressed structural drivers of health. There's, of course, what you can do in the clinic itself. And Rochelle gave beautiful examples. I'm not even going to go through those that I list here. She gave beautiful examples of how clinical practice can really engage with social determinants to create what she calls equity care. Then there is, and what she described also involves reaching out to non-health sectors, such as housing agencies, legal aid, schools, cultural arts organizations, urban planners. And then very robust community partnerships are important. And these are just two images from two different programs that have been really effective in bringing addiction treatment into settings and repackaging it with other types of approaches to addiction that are much more not only culturally resonant, but trusted by marginalized communities. So for example, I'll get to this in a moment, but on the right-hand side, Imani Breakthrough is a project to bring addiction treatment delivery into Black and Latinx churches. And we're actually going to have the woman in the center, Ayana Jordan, is an addiction psychiatrist who's running clinical trials of this approach. She's going to be presenting for our seminar series next Friday. So I hope you can join us to learn more about that. That's just one example of community partnerships that allow us to address structural drivers of health inequalities. And then, of course, there's the level of public policy. We, as clinical practitioners and researchers, have been relatively silent when it comes to policies that have a huge impact on our patients' health. But it's not a part of our clinical training to learn how to advocate for policy change. That can change. We can actually build it into our training. And so that's a part of the vision for structural competency. And I just want to go back very quickly to the website because we're busy, again, reaching out to you and your colleagues to join us in this effort through our network. We have this website as a way of making joining our network easier. You can register for it. You can also get training materials and resource materials that we're busy posting on this website. Okay, and so now that brings us to another project that I launched with colleagues that I think has a lot to do with the new research theme. Given how limited our scientific understanding of the mechanisms by which, exactly how social conditions shape biological outcomes, because we know that there are social environments that are pathogenic. But we don't often know exactly how they work. And this is a moment of the ascendance of life science models such as epigenetics, neuroplasticity, the microbiome, that all call into question social environments that cause biological changes, often intergenerationally. But that science is in its infancy. So that's another place where collaborations between social science researchers, life science researchers, and clinical researchers can be very productive. And this is a a research network that I co-founded with scholar of structural racism and health, Dorothy Roberts, as well as with life scientists, including psychiatric epigeneticist Dolores Malaspina. We call it Symbioses, a biosocial network, research network. And it's a collaborative venture of life scientists with social scientists and humanities scholars of medicine that want to foster new multidisciplinary approaches to understanding how social environments influence biological outcomes. And to wrap up on that note, I'll just take one moment to focus on the term translational social science, because it's, I think, relatively new and bears explaining since it's in the title of our new research theme. So my working definition is that translational social science involves drawing on social sciences as basic sciences of health. So in order to understand the social and structural determinants of health, we should tap into the deep well of social science, of medicine and health that can inform it. So that involves, foundational and cutting edge methods, theories, and scholarship from sociology, anthropology, history, political science, economics, social psychology, to name a few. And these can serve as the basis for biosocial research on the mechanisms underlying the social patterning of disease and the collective promotion of health. Translation between social science research and clinical practice means examining medical phenomena to uncover social processes that explain them. And it also means applying social scholarship to clinical system and practice development. So it's bidirectional. Social insights and clinical interventions should inform each other. And I'll just end by saying this segment, by saying that this is a rare opportunity, as Rochelle highlighted. It's a moment of public attention to social determinants of health, given inequalities in COVID-19 prevention, treatment, and mortality, public awareness of structural racism and class inequalities in law enforcement, housing, employment, education. We're now using the term deaths of despair to signal the economic conditions that are leading to many of our poor health outcomes, including the opioid crisis. And medical inattention to social conditions helps to explain why the US has the worst health outcomes in the industrialized world, but spends more than any nation per capita on healthcare. So what will this require? Because academic medicine has not integrated social science into its training and practice, most medical school faculty, and medical researchers don't have the tools of social science concepts and methods. So we have to build a translational social science workforce by investing in interdisciplinary collaborations and training to enhance the rigor and effectiveness of academic medicine in addressing pathogenic social conditions. And UCLA has the resources to be a national leader in this. It has a high density of well-known social scientists of medicine, but they primarily work on the North Campus, on the arts and sciences side. So enhanced interdisciplinary research collaboration and training opportunities in social science, for example, for joint degree candidates, student and postdoctoral fellows, will help to build a new cohort of translational social scientists at UCLA that will lead the nation to socio-medical knowledge generation and intervention. And on that note, I'm going to switch to our research theme summary slides. Will be just a moment as I pull those up. And then hopefully we'll have some time for discussion. All right. Would you like to begin, Rochelle?
Sure. That was amazing. Thank you, Helena.
Likewise.
Just extraordinary. Thanks for orienting everybody to what you have done. So this next section, we're going to go through our vision and mission, and basically the development of our charter for this health equity and translational social science theme. We were very fortunate to have convened our advisory board group just a couple of weeks ago. So this document that we'll share with you, or these slides that we'll share with you, has been informed by our great advisory board that we have pulled from the community, Department of Public Health here in Los Angeles, North Campus, School of Medicine, all represented in our advisory board. Okay, next slide. So the vision of our theme is that health equity and translational social science is to create equity-centered patient care models in concert with research that centers social sciences, humanities, and community collaboration. And we invite you, we'll have time in the end for discussion, but we invite you to comment and critique our vision, mission, and charter elements of this. Next slide. I'll turn it over to you, I think. Yeah.
Well, yes, so this part of the mission, kind of a why, I think that Rochelle's presentation really clearly laid out this mission, this rationale for the mission. We really can't afford to wait for real attention to social determinants of health in research and in practice. And so the first couple of mission bullets really refer to what I was just laying out, the idea of translational social science, and just using that as a principle for building an inclusive scholarly learning environment that bridges social scientists with clinical researchers and faculty at UCLA to propagate novel projects and programs and encourage the next generation of researchers to advance collaborative scientific work. Do you want to take this slide, Rochelle?
Sure. Also as part of our mission, fostering an engaged collaborative group of social scientists, humanities scholars, clinicians, community partners, and learners to improve population health, and developing an equity-centered patient care model that will integrate the lived experiences of our communities with social and medical care at UCLA. It's just absolutely essential to be able to provide equity care and comprehensive care. And then finally, advancing the development of equity-centered patient care models with translational social sciences and humanities research to guide the implementation and improvement of the effectiveness of equitable care for all. And what's really great about UCLA right now is that both UCLA Health and the School of Medicine has these incredible initiatives happening. There's an EDI director now at UCLA Health, Medell Briggs Melanson, and there's a health equity theme within the curriculum of the School of Medicine, many of you know. These are all, and Reach UCLA, a grassroots group that has formed. These are all opportunities for us to partner up and bounce ideas, concepts, and finally action all together. So it's an exciting time, and we feel like one of the spokes in that wheel.
So speaking of that, we are rapidly building partnerships in this project, and this is a graphic representation. We're really committed to drawing from all parts of the UCLA campus that don't often or often enough communicate and collaborate on research and other projects. But as Rochelle mentioned, we're also deeply committed to community partnerships. So with organizations and agencies that are outside of UCLA that are going to be critical to our success. And one of them listed here is Charles Drew University. Even though Charles Drew has long had a formal affiliation with UCLA, I would say we're finding that we've really underutilized our affiliation with Charles Drew, given that they have pioneered many models of equity care and also research that really foregrounds social determinants. So for example, they have an urban health institute that is largely based on community participatory research approaches. So that's one exciting partnership among many that we've already started cultivating through our research theme. And then Rochelle, would you like to take pillars?
Sure. So there were partners and there are pillars. And so the pillars part of HETSS is building the field of translational social science, as Helena had outlined for you. That is fostering collaborative ventures and creating funding opportunities in social science and health humanities research. Health equity in practice, those are the equity-centered patient care models, demonstration projects of integrating social care. Training opportunities, we really do want to lift up the idea of translational social sciences as as an academic pursuit for undergrads and graduate medical education, to really stand it up to be able to study and understand throughout the models of equity care. And scholarship goes along with that too, seed grant funding to develop new collaborative multidisciplinary research on health inequities and ways to mitigate it. And in these elements, community is involved. It has to be. We have to have our community with us to understand the practical, pragmatic, and useful sides of what we're building. And then Helen and I are excited also to help out with the other research themes at UCLA in integrating not only equity, but inclusion and diversity into other pursuits. So even when you're thinking about doing something like basic science, there is an element there, of course, of diversity and inclusion that should be considered, and we hope to be able to be part of that.
Thank you. Well put. So to recap our core activities, and we put front and center collaboration with community partners to incorporate the lived experiences of people that we want to serve, to deliver equitable care through our research, through our practices informed by that, and definitely to grow the evidence-based for equity-centered patient care through community partner demonstration projects, because often what we find when we are advocating for addressing social determinants of health in healthcare is that our more traditionally trained and focused colleagues will say, well, where's the evidence base? How can we prove that this is effective? And by definition, we have an evidence base that largely includes technological solutions that don't have specific attention to health equity, to the experiences of marginalized communities in them. So it's a vicious circle, you know, when we ask for evidence-based medicine, the well of well-funded research that produces evidence is tipped, you know, the scale is tipped towards technocratic solutions and things that don't center health equity. So we need to build the evidence base, so to speak, and also bring evidence from, for example, social sciences of medicine and population health into clinical spaces so that they can be drawn on as evidence-based approaches. We also are developing seed grants for pilot studies to foster the kind of multidisciplinary, collaborative, community participatory research that is the centerpiece for this theme. And we're working hard to develop training opportunities in health equity care and translational social science. So, for example, we've already begun working with colleagues inside and outside of UCLA on research training opportunities in this area for undergraduates, for graduate students, for medical students, postdocs, residents, fellows. So that we really believe that training is important. Investment in the new generation of people doing research and working and practicing in academic medical centers and community health centers. We also, this is an example of the educational seminar series. So we're kicking off right now the seminar series that we envision. And we want to track both the threads of equity care, models of successful programs that address social determinants in their clinical practice. We also want to foreground translational social science by hearing from social scientists of medicine and interdisciplinary scholars who have brought, including humanities scholars, who have brought specific and rigorous attention to the social as it bears on health outcomes and the practice of medicine. So you're going to be getting, hopefully you'll be getting through email a list of upcoming events that really focus on both of those areas in our seminar. And then also we want to integrate equity and social sciences and humanities expertise into other research themes. This has already come up, actually. We've been meeting with our colleagues from the other 6 research themes that include, much more traditional kinds of bench science pursuits, like research on cancer, cardiovascular disease, neuroscience. We've already had very healthy conversations with them about the ways that explicit attention to health equity and communities that have been marginalized from medicine can be addressed in their work and hasn't been previously. Also, attention to their own scientific workforce. It's not a secret that bench sciences really are quite non-diverse, not only in terms of race and ethnicity, but women also are quite underrepresented in bench science research at medical schools. And the studies that my social science colleagues have done of the impact of diversifying the scientific workforce, the life science workforce, have shown that people who are not white men, essentially, actually bring very different approaches to life science, and they ask different kinds of questions and make different insights, bring different insights to their work. So actually, it improves the rigor of life sciences to have diversity among the scientific workforce, because all of us have blind spots in our work, and all of us bring our life experience to bear when we practice science. So the best way to build the rigor of the life sciences in medicine is actually to increase the diversity of the scientific workforce. So these things are already in progress. It's amazing in the few months that we've been working to see that we've actually started work on these. But on that note, I want to thank you and open up discussion.